So I'm just going to kind of go through this, sort of assuming, hey, we don't know, as much as maybe I think you do or you do or what have you. So we'll just kind of start from the ground and go over a little bit about Parkinson's, and then about their mobility, and then what we kind of want for the volunteers to be able to do and look out for when you're working with us at Recharged, okay? All right, and so it's a progressive nervous system disorder, and it affects movement. What happens is there's a chemical in the brain, in the substantia nigra, that is lacking in people with Parkinson's, and it's called dopamine. And dopamine helps to initiate movement and speech. It also helps us with calibrating how we move, how loudly we speak. And the other thing about dopamine is it's our motivator and the initiator, and helps us get started and gets us going and keeps us moving and going. And it usually develops gradually. A lot of people will start with a tremor, many times just on one side. A lot of people will have some rigidity or stiffness. Sometimes if it's somebody that's older, they'll attribute it to just getting older. And so some symptoms that you might see is a person that doesn't really have any expression in their face, and they call that a mask. So you might see somebody that looks like they're mad all the time when that's not the case. They just don't have as much expression in their face anymore. Their arms or one arm may not walk when they swing when they walk, so they're going to be just more rigid and stiff. And then a lot of times people's voice volume gets really low. They might have some hoarseness or some slurred speech. Eventually you might see a stooping of postures, scuffing feet, kind of falling forward type of a thing. And those are usually kind of the common ones. There's not a definitive diagnostic. Most of the time the neurologist suspects something and says, okay, walk, let me see you walk, and that's how they diagnose it. It's not an MRI or a CAT scan. There's some new, I think, a PET scan of some kind now that's supposed to be diagnostic, but I don't know that they're using that much. So it can't be cured, and the biggest treatment is medication. And in addition, there is a surgery that is sort of specifically used for the folks that have a really bad tremor, okay? But most of the time, the treatment of choice is to start off with medication. So tremor is a sign. And it's usually kind of a back and forth kind of a tremor, pill rolling tremor. Some people will have a tremor and be like, oh my gosh, I have Parkinson's, but then it's another kind of tremor that's an essential tremor that isn't Parkinson's. So, you do have to go to the doctor to get diagnosis. People exhibit slowed movement, which is called bradykinesia. In therapy, yes, it's bradykinesia, but when folks move so slowly, they really end up starting to move small. And so we also talk about decreased amplitude of movement, and then rigid, tight muscles. Other symptoms are impaired posture and balance. These folks, a lot of times, if they're sitting still for a long time, will get into a posture and just stay there, okay? Their body doesn't calibrate themselves to actually fix it. You and I, we start slouching in about 1 or 2 minutes, we're gonna be like, I'm slouching, I need to get my posture better, or we'll adjust, okay? And so these folks just stay there, okay? And if they realized that they were doing this, they wouldn't do it. And that's just it. They don't really realize that they're sitting there. And so over time, their posture just gets much worse. And so most of the time it's a flexion type problem, and so all the activities we do, we try to encourage extension. Speech changes, soft voice, slurred speech, really quick speech that all blurs together. And then a lot of people will notice their handwriting change first. Really small, really tiny writing, almost to a straight line sometimes. So the medication of choice is carbidopa-levodopa, and this is just mostly there's other medications out there, and we took out some of the medication stuff in this because the details aren't all that important probably for what we're doing. But carbidopa-levodopa is a synthetic form of dopamine, and so it has a half-life, and the timing of it is important. Okay, and so people with Parkinson's disease that are on Sinemet need to take their medicine at a particular time. And when they take their medicine and it starts to kick in and they feel like they can move better, that term is called being on. When their medication is starting to wear off and they're getting more rigid or just having more difficulty with their posture and balance, that term is being off. So about the only thing to, I guess, take away from this is that their medication and the timing of their medication is very important. And so if they're on a 4-hour schedule, 2 tablets every 4 hours, or 1 tablet every 2 hours, something like that, they need to be encouraged to take it, and they need to take it on schedule. We have one client now in Recharged who I have a standing alarm on Wednesdays at noon on my phone because he needs his medicine. And so one of the criteria in Recharged is that they can take it themselves. We can facilitate it and say, okay, it's time to take your medicine, but we can't really actually give medication. And there are other medicines other than carbidopa-levodopa, but carbidopa or Sinemet is the drug of choice. So dosing, usually it kind of depends. A lot of times another way of determining whether you have Parkinson's or not is, here, try Sinemet. If it works and you feel better, guess what? You have Parkinson's. So sometimes the dosing just depends on your symptoms. It's usually if a person feels better and can get moving and is not so rigid and stiff. A lot of times physicians will start with 1 or 2 tablets 3 times a day, and they'll figure it out as they go. Side effects: nausea, sleepiness, dizziness, headaches. Sometimes you can have confusion and hallucinations. Those will show up kind of right away, or if someone's been taking a lot for a while. And then if you have too much Parkinson's medications, you can get what are called dyskinesias. And dyskinesias are those, it's not a tremor, it's more of a constant writhing movement. So you may have met some people that have been on medication for a long time and they're kind of constantly moving, and that's a dyskinesia. And so that is one of the side effects. So therapy and treatment, medication, and then exercise. Exercise is key. I'd say probably in the past 15 years, neurologists are starting to be a little more open to the fact that exercise is key. They used to really think that it was just medication. I've had a couple of neurologists say, oh, I just have to adjust their meds and they'll be fine. And I'll be like, come on, let them get some exercise. And so these are some of the therapies that are specific for Parkinson's: LSVT Big, Power, Rock Steady Boxing. I don't know if some of the cycling programs have been, at bona fide Parkinson's programs, but those are good. But I think those are the main ones that are sort of advertised as specific to Parkinson's. And then LSVT Loud for the speech. What is LSVT? LSVT stands for Lee Silverman Voice treatment. And so in 1987, a patient named Lee Silverman, her family just wanted to be able to hear her. She'd gotten to the point where her voice volume was so low that they couldn't hear her. And so they started doing studies with just paying attention or emphasizing loudness. And all they did in their treatment sessions, instead of saying, maybe, well, sit up straight and move your mouth like this, they would just talk about being loud. And so when we get loud, many times our posture gets bigger, our mouth gets bigger, our eyes and our face gets more expressive. And so they were doing these exercises of repetitive vocal loudness with a, it's called an audiometer, so that they didn't feel like they were screaming, because I'm not a quiet person by any means, but I don't have a low voice volume anyway. So when I talk loud, it sounds like I'm screaming. And so they had to learn what was normal vocal loudness. And so they had efficacy studies that when people practiced their voice exercises repetitively, you had some motor relearning. And so they said, well, how can we do this with movement? And so you have LSVT loud, and then you have LSVT big. So they did the same thing with movement and tried to get people just to think about moving bigger and to do it repetitively, so that there might be some new motor learning that would occur. And you could tell that person just in like one phrase, oh, let me see your big posture, instead of stand up straight, don't bend your knees, don't slouch, it's a little bit more positive. So LSVT big is high effort, big range exercises, repetitive. And so like I was saying, the principles of loud are applied, and we're trying to reteach normally big movements as well as normally loud or vocal loudness. And the idea is a repetitive activity, so that hopefully it'll become second nature again, or clients will recognize when they're being quiet or moving small, and stop themselves and recalibrate and move more normally and speak more normally. And POWER is called Parkinson's Wellness Recovery, and it was actually designed by the same therapist as LSVT Big, Becky Farley. I think they just had a little bit of a business split. And so LSVT is a little more rigid, and you have to do it this way, and whereas POWER is a little more just make movements bigger and powerful, but we can do it with anything. I'm not a speech therapist, but a treatment session with a speech therapist would be practicing ahs and trying to hold that, having high vocal pronunciations or exercises, low ones. They'll teach somebody to practice just functional phrases, and they need to be whatever is pertinent to those people. So if Joe always asks Susie what's for dinner, then he needs to practice what's for dinner, Susie, instead of what's for dinner, Susie. And then they get more difficult with the activities, and so it's just repetitive. And these people, both programs, the mobility program and the voice program, it has to be practiced daily. Otherwise, what we've seen is that folks just go back to kind of where they started. And so it just needs to be a mindset of doing this every day. So some terminology, and you'll pretty much see any of these. So freezing is a motor term. Somebody knows they're trying to walk forward or trying to turn, and so they know that they're trying to move, but they're stuck, okay? They can't move the one leg, and we do have one client, and so like if you came to volunteer with me, I would say, this gentleman freezes a lot, so you need to be aware of that, and that's what I'm talking about. They want to go and they can't go and they're stuck, and so usually we'll use counting techniques like, Move your foot nice and big, 1, 2, 3, and then they can go. So freezing is just stopping in your tracks. They know they're trying to walk, but they can't. Sometimes visual target. All right, so head over there to that chair. Look at that chair and go to it. Counting, singing. It's like a skip on the record, and if you can move the needle, then that's great. And so any technique you can do to move the needle. Festination is those little stutter steps that you see usually at a transition. And a transition is any time you stop or start, stand, turn. So when they first stand up, they might do this and then kind of get their stride going. People fall a lot right then. And so if you see them doing that, you want them to, if you see them festinating, get them to stop, get a big posture, and then take off big would be the things that you would say. Snowballing, a lot of their postures like this. They get going like this, and they may fall. I've had clients that strategically look for walls so that they could crash into them and catch themselves to stop. I mean, that really severe case there. So that would be something to watch for in our group. If somebody is really kind of tippy, woo, you want to go and get them to stop and get their balance big. Being on and off, I kind of mentioned with their medications. Okay, they usually can tell about 30 minutes to an hour after their medication has kicked in and they feel like they can move, or when it's wearing off, and dyskinesia, as we went over already. So how do you help with mobility? So encourage big posture, encourage big steps. Sit to stand is really hard for people with Parkinson's, and pretty typically with the folks that are in our group right now. So you want to really emphasize some momentum and some big effort to get up. Nose over toes, and really need to be leaning farther forward to get up. When we're doing activities reaching big and powerfully, like today we were doing cards, and you would see folks not really reaching to the deck to discard their card on the deck. Okay, so any of those things are important for us to help them. Go on, reach big. Go put your card down on the deck instead of doing it for them, or moving the deck closer to them, or what have you. Encourage them to speak in their loud voice so that you can hear them, the rest of the crowd can hear them. And if you see them doing the festinating, get them to stop and then start off big again. Treat and speak to the clients like you would anybody else, okay? Some of our folks do have some recognizable dementia, but all of them are conversant, very appropriately conversant. So just talk to them normally. Allow them time to respond. So I think what's really hard is to either not talk over them or to do it for them. And like today in the card game, I would watch the people's eyes to see first if they knew like it was their turn, and then see if they were just thinking what their next move was. I had a client who I counted one time because I felt like I was talking over him sometimes. It took him sometimes 30 seconds to respond to the question I asked. He still had the question in his head. He had not forgotten it, but it took him that long to answer. And then likewise with mobility. If you had said, okay, we're going to get up and go do this, give them a few minutes, see if they're going to get going, and then if not, repeat. Yep, so we already talked about loud. Definitely we want to encourage them to do the movement. We don't need to be pulling on them. Every now and again, folks will be like, oh, pull me up, because they've kind of gotten used to that. Maybe that's how they do it in their family, and that's a good opportunity to do some teaching, but get them to start the movement, and then we help with it. And I don't know exactly who all will be doing what, but since we have some PTs in the room, and I'm a PT, I do more of the mobility with the folks who are fairly involved. Volunteers who don't have medical background do some spotting, and I'll kind of say, oh, you know, will you take care of so-and-so? You're not required to do a lot of heavy lifting or anything like that. Now, if it's something that you're used to, you guys are PTs and you know what to do, great. And so that can be we can figure that out on a each time basis. Does that make sense? Okay. And yes, many times people with Parkinson's have sort of decreased insight to their deficits. They think, oh, I'm fine, I don't need my walker. They do, especially here. Okay. All right, so you're going to wait for somebody to start moving. Usually you're going to want to be kind of at their side, back fairly straight, legs bent. A lot of times I'll just kind of rock and go with them. You definitely don't want to be picking anybody up or anything like that, just using your back. A lot of these folks need a good amount of help getting that forward momentum to get up. And so, you know, a lot of people will try to just get straight up, you know, and then they fall back against the chair or what have you. And so we're really trying to get them nose over toes, like I said on that other slide, and really get them forward. And then to come up, and really if you can assist them with that forward movement and they sort of tip the scale and actually get up, then usually you don't have to do a lot of pulling on them. And can I have a volunteer? Yes, will you be my volunteer?
I remember because I did it last year.
Yeah.
So let's see if it's the same.
You know, a lot of times a person with Parkinson's is going to be a little bit stooped. So let's say they're a decent ambulator. You could just be right here with the light hand and maybe back here at their hip and waist to just promote extension. So it's basically going in the opposite direction that they're inclined to go. So if they're here, then you're just going to want to be here to kind of help them. You could use a hand on their arm. Right now our folks, thank you, are really pretty slow. We don't have anybody who's too energetic, so we're not having to do a lot of pulling or holding right now. Yes, we should have gloves. So we will. And I know we have them. I just haven't put them in our little box. But we usually just walk the person to the restroom, number one, to make sure they don't get lost. And then I check on them. I really haven't had to do any cleaning. And since I'm in the medical profession, I'll be the one that would do that if it were necessary. So yeah, really it's more walking them there, making sure they're safe in the bathroom. If we know that they're not real safe, we're going to keep an eye out for them because they're going to try and get up because they pretty much think they're safe and able. And again, I think I've been the one that mainly does that with our folks that need more assistance. But if it's somebody that's walks well and can take care of themselves well, I would maybe say, oh, would you take so-and-so to the bathroom, and then you just listen out for them. And that's why we have to at least have 2 people in the room at all times, and then depending on our numbers, because we can't have one out and then no one with the clients. And then if for some reason you need to assist with cleaning anything, you're going to have your gloves on while you're doing that cleaning activity, okay? And as soon as you need to leave or touch a door or touch anything else, your gloves have to come off so that you don't contaminate a surface. And then if you need to go back to assisting with cleaning any kind of blood or body fluids, you would re-don some gloves, and then of course washing hands afterwards. And a lot of times too, our folks will forget to wash hands, so that's something you can do too, is just guide them to wash their hands when they're leaving the restroom. If we have an emergency, we call 911. Okay, if you're teaching and background calls you to take action in an emergency, you certainly may, but you're not obligated. I do a screening, and so we have a file folder of medical information and emergency. We have DNR information in those folders, and so we have to remember to bring the folder in the room with us every time, so that, let's say something happens to somebody, and we could look and just see if they had a do not resuscitate request or not. And so that bottom one I kind of went over. You're not required to do CPR. That's more up to you. So what I try to do in the group is we usually have a tabletop activity, let people get there, get reacquainted. We'll do some orientation type activities. People with Parkinson's are pretty notoriously a little bit late because it's hard for them to get going. Got some that are really on time and some not so much. So we do that at first, and then I try to do some kind of a movement section, and then we usually have a snack, and then they usually go home. So one thing I've noticed at times is, let's say I'm up assisting somebody that's a little more physically challenging, and one of the more active people, but maybe not all the way safe people gets up, that's when it's a little scary. I'm over here, and so that second volunteer, I'd say be overprotective. It doesn't mean that you have to have your hands on them, but if you see Susie getting up, hey, what are you doing, Susie? Go over and kind of find out what's going on, make sure that they're just at least supervised. That's pretty much been the main thing.